Well, good afternoon, everybody, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name is Jason Belden. I'm the Director of Emergency Preparedness for CAF. And today, Patty is meeting with the CDPH at 1 o'clock. So Patty will not be able to join us today, but I will walk us through the AFLs that came out. We mentioned them briefly last week. They're very minor, but we'll cover the where it differed from previous versions. We'll talk about the CDC MMWRs, the Morbidity and Mortality Weekly Report. There's two very interesting research studies done in there. We'll cover those in depth. Talk about PPE. I missed one section last week from the CDC guidance. I cut it out and put it with the correct link. And so we'll review that and then talk about the CMS waivers. My hope is we should be able to finish this up well before an hour, but it'll depend on your questions. And as always, if you have questions, please put them in the chat box now so we can download those if we're not able to get to all of them. And then we do have 4 handouts for today. One handout's obviously the slides. The other one is that information brief with the forecasting for the virus for the state and different regions within the state. I include those a couple times a month, so that's in there as well. There's the QSO from CMS is in there where when we talk about the waivers, that's included, as well as a meeting agenda and an invite for any of your infection preventionists if they want to attend a free seminar given by the Greater Los Angeles Area of Infection Preventionists Association. And they'll, I'm going to be speaking on it, but there's a number of other speakers there. So if you have an IP that would like to attend and take a listen to that stuff, my hope is I'll present a very good presentation for them. So if you have IP folks, we'll talk about specific to IP and what their role is during disasters. All right, so we'll move on with our formal introduction. The speaker's opinions expressed are their own, and they may not reflect CAF's official position. These webinars are brought to you as a part of grant-funded programs, both with the Los Angeles County and with CDPH. I have no personal financial conflicts. I'm employed by CAF, and we're not promoting any material here. The intent of the webinars is to give you a situational report. You know, we review any AFLs or existing regulatory changes and try to explain those to folks, as well as forecasting and best practices where we can identify those. All right, let's hop into our first update here. AFL 20-22.7. So this is the 8th revision of this, or 7th revision of this AFL, 8 total. Really the revision, we talked about this briefly last week. It includes additional visitation guidelines for pediatric residents. And I know there are a few pediatric subacute facilities. This is definitely geared towards you guys. And there were a few questions on the HSAG and the conference calls about, you know, what kind of contact would be allowed between pediatric residents. And the person on the call was asking because the parents were very interested in being able to touch their child. And I just, you know, as a parent, you just go, oh man, how difficult would that be? But there were some exceptions written into there. So if you have fully vaccinated visitors, they're allowed to have physical contact with the residents, even though the pediatric residents haven't been cleared to receive the vaccine yet. And then they did put in this bullet point. I know this is not many of you guys, but if you're a pediatric subacute, please encourage everybody, staff, visitors, residents, because these folks, because these young people cannot get the vaccine, we want to encourage everybody else that's around them to get the vaccine to protect them. That's obviously, it makes sense, but we want to double down on our efforts to get the visitors vaccinated so that they can be close to their loved one. In terms of the AFL 21-22, this is the AFL. Now they changed the number. They had put it as a part of an AFL 20-25, and then they changed it because in that AFL 2025 it applied to all healthcare facilities, and they wanted this specifically to apply to hospitals only. And so I don't know if you remember when we discussed this last week, that was one of the questions I had. We brought that question up to them on Friday, and then they immediately changed the AFL to indicate that this was for hospitals only. The only good news here, well, the good news for us is this may facilitate more discharges coming fully vaccinated from the acute. And if that's the case, hey, you know, heck, we support it. We'd love to have this exception for skilled nursing facilities as well, and we'll work on that. I'll talk in a little bit about the meeting we're set to have with them on Monday, and ask you for some agenda items if you have suggestions. All right, let's hop to the CDC MMWR. The first one I want to talk about, there were two research studies done. Both are going to be linked. So under that MMWR link, that link goes to this, the study that was done in the Chicago area. And so this study was not done on a specific facility, but was done on a group of facilities within the Chicago area. So essentially they looked at 75 total facilities, and out of those 75 total facilities, 72 of them had at least one positive COVID-19 test. Out of those, 72 facilities that had identified cases within the period in which they looked at. And they looked at a pretty long period of time. And they broke out different categories for non-vaccinated, partially vaccinated, and totally vaccinated. And I really want to concentrate on both the fully vaccinated and the non-vaccinated. The folks that are in the partial vaccination state, we're going to get them to be fully vaccinated. So really, it just so happened that they were in the middle of it. And I don't know that we can learn a lot from that data that's in the middle there. But for the tests that were done, there were a total of 627 total positive tests out of 15,000 tests or thereabouts. So they're not a high positivity rate within the Chicago area, which is good news for them. There were 22 positive cases, 22 out of the 627 total positive cases were in folks that had been fully vaccinated. So that's 12 residents and 10 staff out of the 627 that were fully vaccinated and then contracted COVID-19. 6 of those were in previously positive individuals, indicating that it was probably a reinfection that existed. Now, they did not do, there were some things that they did not do in the study. They didn't do CT values of the positive folks, and they did not do whole genome sequencing. So we don't know what strain of COVID they were looking at. Because they were looking at such a broad spectrum, I think, of facilities, they were only looking mostly to kind of capture data on how the vaccine is performing. There were 2 hospitalizations of previously positive residents or of vaccinated residents, and one of those residents went on to pass away. There were obviously worse outcomes in the non-vaccinated kind of control group. But the real kind of highlights from this study, and I pulled this language right out of the study, that most fully vaccinated persons were not infected. Now, to the level in which they were exposed, we don't know. That was not quantified in the data. And when you're looking at 15,000 people, it's hard to really figure out what was their actual exposure, whether they were exposed or not, or whether they were just in a building that had an outbreak. Breakthrough infections, and this is incredibly important to us viewing how the vaccine affects preventing transmission within the building. So breakthrough infections did not lead to secondary transmission at these facilities. And so that means for those 22 folks that had tested positive after they had been fully vaccinated, none of them had been shown to lead to secondary transmission at any of the facilities that they looked at. And these 12 residents and 10 staff were divided across a number of different facilities. They didn't all come from one facility in terms of their positivity. What they found was that those folks that did become positive with a breakthrough, they didn't then transmit the virus to somebody else within the facility. And that's incredibly important information, and it's really good news for us. If that continues to hold, that will be fantastic. There are some other things the vaccine might not do as well, but this is one of the main things. Like if we can, if it prevents us from having outbreaks, that's great. The vaccine effectiveness was not calculated in that particular study. All right, I want to hop to the second MMWR that talked about an outbreak in one specific facility. And that outbreak gave us a little better data on how the vaccine is going to perform within a facility in relationship to a new variant. And so the outbreak in Kentucky was studied pretty extensively, and there's some great data and some tables in there. I know there was a question on one of the calls the other day about what is the effectiveness in preventing infection. And now we don't know all of that, and I'll tell you there's some gaps in trying to figure out the effectiveness in preventing infection. If you see that last bullet point, I'll get to it in a second, but there is some data on this. But before you start saying this is the data, we'll explain, kind of how you look at this. It may not be as effective as we think it is. Let's just put it that way. So in terms of unvaccinated residents and staff, the unvaccinated staff had a 3 times greater risk of infection, and the staff had a 4 times greater risk of infection, as did the vaccinated folks. In terms of our most important thing, does the vaccine protect against symptomatic illness? The vaccine was 86% protective against symptomatic illness, and that means symptoms of any kind in residents. So this is a great number, fantastic number. That's really what we want to see. Vaccine was 87% protective against symptomatic illness. And oh, sorry, that second number should be in staff. I apologize. And the R1 variant was the variant that was identified. Now, the R1 variant is a fairly new variant. I was not able to find a ton of information about this variant. There is a MedRxiv investigative study that's available. It really, I just, I didn't include it in this because it's such a small percentage. So just to give you some kind of idea, from the period between October and February 2020 through 2021, the frequency of that variant being discovered in tests was 0.9% in Japan and 0.15% in the USA. And it does not appear that this is a globally predominant strain, but further analysis is going to be needed to determine whether it will disappear or expand in the future. The point is, this is a really unique variant that shares a lot of the characteristics with the California variant that we had, kind of raging through our buildings in December and January. So it does sound like it's more transmissible than previous variants, or the variants that were used to develop the vaccines. 26 of the 83 residents tested positive. So 26 of the 83 vaccinated residents, I should say, tested positive. 26 of the total 83 residents tested positive. 18 of them had been vaccinated. It's important to note that all of the non-vaccinated, and I didn't put this in there, but there were only 2 partially vaccinated folks in this building. All of those 2 control groups contracted COVID, all of them. So there was no exception in the non-vaccinated people. For the vaccinated people, 18 out of 75 were tested positive. And so that's shows that how they determine that 66% effective rate in preventing infection. The facility was testing twice weekly during the outbreak, and meaning they were doing twice weekly testing before the outbreak even occurred. So they were testing really, really frequently. And so that gives you some kind of indication of how transmissible this virus is, and that they, even though they caught it really quickly, it got through the building very, very fast. 3 residents did pass away. There were a number of others that were hospitalized. In terms of the folks that were fully vaccinated, 1 of the fully vaccinated residents passed away, and a couple others had to be hospitalized, but did come back to the building. 4 reinfections were discovered among the positives, meaning these folks had been previously positive, and this new infection, or this infection was a new infection, not a part of a previously positive test. They did CT values on all of the folks, and they did find that even the folks that had test positive, their CT values were really, really high, indicating that it was unlikely that they were able to transmit the virus. In other words, they probably were not effective. So that for those folks that had been vaccinated, they did CT values on those, and the CT values were super high. So yes, they were positive, but they would probably not lead to transmission within the building. And the study goes on to say that there were no secondary reinfections discovered because of this, but because they were testing twice a week, there may not have been much opportunity for it to transmit within the building. It sounds like they caught the outbreak really quickly, but the outbreak was already moving among the residents and the staff. They did go on to list the effective rate of the vaccine, and they put it at 66%. And I want to say, we don't know if that's going to hold true for other buildings. All we can say, because we don't know. So for the folks that had been vaccinated, we don't know what their exposure was, and they. So yes, they did not contract COVID, but were they even exposed to COVID? We don't know that, because we don't know what operations were going in the building. We don't know who they were cohorted with. We don't know, whether they were having group activities with these folks. None of the exposure risks are quantified in there, so we don't know. But they say, based on this study, that they think that it's 66% or 65 point something percent effective in preventing infection. So that's good news, not great news. It does prove that we've got to keep up our infection prevention kind of operational requirements for a little bit longer. It does not sound like we're going to get away from this pretty clean. So, all right. And with all that said, now that we know kind of the ability of this virus and the variants to really come back and bite us again in a second time, I want to double down on what we talked about last week and say that there is now, and I apologize, I did not include this last week. I was searching around for this section where it says that N95s can be used as source control, and it's buried in that link. So if you click the link for the conventional capacity strategies, scroll down to where it says source control. Don't look for the one where it says N95s or respirators. And that's where I was looking for the data, and I couldn't find it. I apologize. So if you click on the source control, it has this this explanation here. Extended use of N95 respirators can be considered for source control while healthcare workers are in the healthcare facility. It covers one's mouth and nose to prevent spread of respiratory secretions, yada, yada, yada. Anyways, the point is that we can give folks N95 respirators and have them use it as source control, even if they're not fit tested. And so this is saying an N95 respirator can be used as a conventional strategy for source control. And so source control is not PPE. It does not require a fit test or anything like that. So if you have non-vaccinated staff in your kitchens or your laundry area or your EVS staff or any of those other staff that have not gone through the fit testing process, you can give them an N95 ask them to wear it as source control. I think it's a great idea for the non-vaccinated staff. All of those situations that we indicate that all of the outbreaks occurred from non-vaccinated staff. And so it's you know, that's clearly our main vector for having this come into our building. If we can do, the most important thing we can do is to protect the residents from what's coming out of the healthcare workers' mouths. And we do that with a respirator if we can. If you still have, you know, here's another kind of maybe a workaround. If you don't have tons of respirators and you want to hold your respirators for care activities, then if you have any of those KN95s left over, those could certainly be used for source control. The KN95s can't be fitted, so they don't have that tight seal like an N95 does, but they do at least advertise that the filter medium itself is the same medium. So in terms of the effectiveness of the respirator, in terms of the, you know, the filter media, that should be the same. Now, I don't know that KN95s go through the same process to submit their kind of designs or their for the masks themselves to NIOSH for approval, but they're marketed as having that same kind of effective rate within their filter. So that may be a possibility. It's certainly probably better than a surgical mask. Anything that's going to reduce the amount of those respiratory secretions, whether it be droplets or aerosols, you know, we want to take the advantage of doing that. So that's certainly within your capacity to do that now. And I apologize, I didn't bring that up last week. All right, I'm going to hop to the CMS waivers. Now, not all the waivers are expiring. I'm just going to cover the ones that they carved out that will be expiring or that are changing. And I want, too bad Patty's not here to explain this for us, but in terms of the emergency blanket waiver related to notification of resident room and roommate changes, transfer discharge notification requirements, that waiver is going to expire on May 10th, but CMS is only ending the waivers for providing written notice before a room and roommate change and for timing of that notification or transfer. The related waivers will continue to allow facilities to transfer, discharge, or change rooms for the sole purpose of cohorting remain in effect. So if it's a normal resident room or roommate change, it goes through the normal process after May 10th, where you can start back to that process now. You don't have to wait until May 10th, but May 10th, the blanket waiver expires. And then after that, you'll go back to, you can move folks if you have to for cohorting purposes, but outside of that, you got to follow the normal process. In terms of care planning requirements for transfer or discharge residents, those are back in place effective May 10th. And the time frame requirements for completing and transmitting the MDS are back in place. I was going to have Patty explain the clarifications and recommendations for the nursing assistant training. Gosh, let me get it is the nursing assistants training program. Gosh, I'm sorry, I don't have the acronym here, but I did include the handout that Patty gave us for the QSO. And so if you look down for the bullet point on clarification and recommendations for the nursing aid and training programs, that will be listed in there as well. All right, and I'm sorry, there's a link to the CMS section if you want it under the waiver section there. All right, we're trucking right along. Hopefully we'll get you guys out of here in plenty of time to go on to the next thing. In terms of visitor guidance, I wanted to let you know that we are convening a stakeholder meeting with CDPH on Monday. CAF sits on a national group called the Delphi Group with geriatricians, long-term care physicians, folks in our industry it's essentially a work group. There's folks from the Ombudsman's Association and the Alzheimer's Association, so it's a broad spectrum of folks. Anyways, they have created kind of a consensus letter we're going to submit to CDPH asking for some changes to visitation. And we were heavily involved in some of those asks. Nothing in it is particularly difficult for us. I think it's more, we're asking for clarification on visitation policies. We want to encourage visitation. We also want to talk to them about, an explanation or an acknowledgement of the risk benefits of being vaccinated, and allowing those folks that have chosen to not be vaccinated, I'm talking residents specifically, to have them be allowed to have the same kind of opportunities for visitation that that vaccinated folks do. There has to be an acknowledgement of the risk and benefit, but certainly I think it's important that we treat everybody the same once they've had the opportunity to take a vaccine. We'll talk to them about group activities. We'll talk to them about one of the big recommendations that I've made is that we put it in a regulation or a requirement for non-vaccinated staff to wear PPE in the care of non-vaccinated residents. I think that's a low-hanging fruit. If you're a non-vaccinated staff, you should probably wear a respirator if you're working with non-vaccinated residents, just to be on the safe side. And then we're going to talk to them about the removal of zones and what does that look like. Do we go back to being referring providers where we transfer out all aerosol transmittable diseases, or do we treat them like a flu outbreak and contain them in place and treat them with the precautions, the appropriate precautions? So we'll talk about all that stuff. This is certainly messier than we want it to be to draw down these different things. I don't think there's just going to be an on-off switch. I think it's going to be, we're going to go through each one of these things and have incremental changes, which is unfortunate because it's going to be really hard for you to operationalize. In terms of the testing, I don't know that we're going to recommend much changes. I said this before, gosh, we're going to be the last folks, really the last folks in society to stop testing to get a look at what's going on in our buildings. If there are changes to the testing, we may be looking at changes to testing for non-vaccinated staff members versus vaccinated staff members. So those are kind of the things we're looking at. If there are questions or things that you want clarification on, put them into the question box now. And I will make sure that if they're not on the agenda for the meeting on Monday, we will put them on the agenda and we'll discuss them. And I'll try to meld them in. Now, we only have an hour with them, and I'm going to try to get them to commit to doing this, having this planning call, every month or every week, so that we can kind of talk through each of these step-down measures to make sure they're consistent with protecting the life and safety of our staff and residents. Make sure they're easy to operationalize, or at least accomplishable by you guys. And easy is a poor choice of words. Nothing here has been easy for us. So, all right, I'm going to hop to the questions, and then we'll get you guys out of here. First question, LA County updated recently its guidance on visitation, stating that general visitors who visit the facility at least once a week or more should be tested at the same frequency as facility staff, regardless of vaccination status. If they visit, we started offering the test to be done in our facility or elsewhere, but we've gotten a lot of pushback and refusal from visitors, especially, sorry, I lost the question. Especially for the partially or fully vaccinated visitors. Can we restrict their entry if they refuse or cannot present a most recent negative test? And I think that's a great question. The folks at Los Angeles County have created that. That is a health order, so it's enforceable by law. Those are requirements that you're required to follow. It's not really an option. So for them, if they tell you the visitor is required, I'll have to look at the language. If it does say that they're required to be tested rather than to be offered tests, then they have to test or they can't come in. But if it just says you have to offer them, then that's all you got to do is offer the test, acknowledge somewhere that they refuse to be tested. And if they're fully vaccinated, I have a lot more confidence in, especially now that we know it's unlikely that based on the early results, it's unlikely that even if they were positive, they may not even transmit it. So that part gives me a little confidence that they've been vaccinated. If they've not, I would encourage it and say, hey, we've got the ability to test you right here. Let's get it done. It's going to take 15 minutes. If that doesn't work, I think you just acknowledge that you offered the test, have them sign that they refuse to test, or at least you document that they refuse to test. But all that hinges on whether the language says offer the test versus require them to test before they come in. So I apologize. I don't know it specifically. I'm assuming they say offer the test, and if that's the case, then that's all you can do. Does the new CDC guidance work for Cal OSHA compliance? And that's a great question. Cal OSHA has not really has essentially said that you could use an N95 as source control, but they have not said that you should essentially hand those folks a respirator. I think they would defer to CDPH to say that rather than us. Next question, Jason. It's been so hard to do visitation with the amount of staff we have. It's been very hard. We are managing. It's not easy. Yeah, I really encourage you guys to develop the visitation plan that works for you guys, that you can schedule and still maintain that. I know how incredibly hard this is on families. I just watched a video of a son hugging his 102-year-old mom for the first time in a year, and it just brought me to tears. It's really hard for them. It really is. And so we have to do our best to try to say, gosh, I'm doing everything I can, guys. I just want to protect your loved ones. That's what this is all about. It's not making it hard for you to visit. It's making it safe for your loved one to still be here for you to visit. And I realize that's a hard conversation to have with folks, and folks really don't want to hear it, especially they've been vaccinated. They just want to get in and see their loved one, and they don't really care about, your operations. It's important that we highlight to the folks that are visiting, we do this because we care about the protection of everybody in the building. And so until we are safely outside of this, we're going to have to schedule these visits in a manner that maintains that safety. That's really all I can do. It's customer service. I know it's hard. It's like being a Comcast, tech service agent. You're just going to get the blues from everybody. Everybody's not going to be happy, about it. Unfortunately, you've got to make those hard decisions for the benefit of the residents as a whole. How long is the daily COVID reporting going to go on? That's a good question. That is on the agenda of the things that we're going to talk to folks about. I will say, I don't know that it's going to change within the next few months. So I would say, at least 2 months, you're going to continue to do these daily reports, possibly longer than that. I think what may end up occurring after this event is daily reporting is going to be an ongoing occurrence, meaning some format in which we check in every day with CDPH is on the horizon. The hospitals do that now. Every day a hospital goes to work, they check in, they put their bed capacity in the different categories. Now, obviously, they have more departments than they do. They have ER and maternity, and they have NICU and PICU, and each one of the different departments puts in their bed capacity. That's reported daily. I think there's something coming like that to skilled nursing. So yes, I think maybe the COVID and that long giant survey that comes out every day that you have to repeat calls with the department, that may go away. But the process of daily reporting, I just don't see it going away. I think something like this is going to stick. So yes, the big reporting may go away, but daily reporting, I don't think that's going away. That's my personal opinion. That's not CAF's opinion, but I just see the writings on the wall that that folks from a response side, from the operational side, and CDPH and local health departments, they don't have any idea what's going on in skilled nursing facilities. And so when a disaster happens, they have no idea where to put people. They don't know where beds are located. We have the bed polling systems that vary across the state. They're different in different counties. The counties don't necessarily share information with each other. So if you put all of that together, the writing really is on the wall to have us backfill that information. That's my personal opinion. I think it's probably likely to happen. Please ask if we still need to quarantine unvaccinated. Let me expand this question. All right. Please ask, we still need to quarantine unvaccinated patients coming from the acute. And yes, I will ask that. I think it's unlikely that they will do that, but I think what may be the scenario in the future, when this comes, I don't know, is going back to that same kind of standard that we're all referring providers. Meaning we don't take aerosol transmittable diseases from acutes. That person has TB, they're not going to send them to an acute or send them to a SNF just because they need skilled nursing care. They're not going to do it, and we're not going to take them. So do we get back to that point with COVID where we just say, hey, you've got an ATD, I'm not putting them in my building? They stay there until they're no longer require any kind of precautions. Then I can put them right into my green and I'm good to go. I think that's probably more likely where we're going to get to from the current guidance. It's just too hard to operationalize one yellow zone resident and to have dedicated staff. Now they've come off the dedicated staff a little bit, and they've said, well, yeah, we understand if you only got 1 or 2 or 3 residents that you can't have staff dedicated to just them. So I think we're going to get to that point. I just don't know when we're going to get to it. In the interim, we're still going to have to cohort those folks. In regards to testing for vaccinated, at least can we follow the QSO of testing 25% a week, so all are tested monthly? That's a good question. That'll be one of the things that we talk about. I don't even, it may be, and I've got some other clinicians that are going to be on the call that will help me kind of advocate for this. I don't know if the 25% a week is better or if we concentrate on the non-vaccinated staff. And it seems like really we've narrowed down where the vector is, where the 99% or 98% of the exposure risk looks to be coming from those unvaccinated staff. Or anybody that's not vaccinated. It could be a non-vaccinated resident coming from the acute. Just imagine if that person comes with an R1 lineage or some other type of variant, and we don't discover it until they develop symptoms, and by that time they've already transmitted it to other folks in the building. So I think we will continue to look at testing it at a minimum the non-vaccinated folks at a more frequent pace than 25% a week. And maybe that there's a blended approach. I don't know. I think CDPH is welcome of the information. It doesn't mean that they're going to take the information and act on it, but it does. We wanted to bring a broad enough group of folks together to talk about it so that nobody felt like a stone was left unturned to talk about what's best for the residents. And that's all it is when we sit in these groups, is we're talking about what's best for the residents and staff. Are there updated recommendations, guidance, expectations when using nebulizers in non-COVID and COVID environments? Well, nebulizers, are, I know we don't think of those things as aerosol generating procedures, but they really are. And I've already seen a couple of studies done, not in healthcare, but where nebulizers have aerosolized the virus, and they've caught other people outside of their area sick. Now, those other folks were wearing masks for source control. So it's one of those things that if this person has COVID and they're doing a nebulizer treatment, that you're filling the room with infectious materials if they're not in an airborne infection room. It's just the way it is. I wish it wasn't that way, but it definitely is. For the non-COVID folks, doing all of that other, kind of airborne infection isolation, it should be the way you normally do it. It should only be for the COVID folks. And we'll talk to CDPH about, whether they feel like there should be a distinction around nebulizer treatments for the non-COVID folks, because I don't think that poses as much risk as for the COVID positive folks. Next question. For ICFs with residents under 16 years old, is there any information on vax for the younger age group of residents? And sadly, no. I know that there's been some studies that they're doing on younger folks, but I just don't think there's not a big push to do this, especially, given the fact that that seems to affect younger people less so. And so I don't know that there's a big push to address vaccinations for those under 16. I've not seen it. Doesn't mean it's not happening, but certainly not soon enough for you and for your younger residents. I think for those folks, the best we can do is connect their loved ones and with the ability to get vaccinated, so that when they visit their son or daughter or loved one, that they're at least doing their part to protect them. And then really, really, highlight how important this is for your staff to get vaccinated, and just how we can't get these folks vaccinated, so it's up to us. It's our responsibility to do it on their behalf. I hate to put it that way, but for those folks, it really is like that. And if you work in a pediatric facility, it really is that case. Okay, next question. Why do they require healthcare professionals and vendors to be tested before coming in the building, but they say for visitors it's not required but recommended? Well, I think that just, they can require it because they have a lawful authority to dictate the terms in which our facility operates, but I don't think they feel like they have the regulatory authority to require of the general public. And so for those folks that come in, I think there's some things they can dictate, that we have to do screening and all this other stuff. I don't know that they can require testing legally, and I think that's why they've stepped away from that. And they're very sensitive to public perception, CDPH is. And so I think there would have been serious outcry from the folks if they were mandated to be able to do that in order to visit their family member. Now that surveys have restarted, can they share what our survey window is? How is priority established? That's a great question. I don't know the answer to that, but I will ask Patty. My assumption is that they will go back and well, first they've told us that they're going to really kind of divide these up. They really want to concentrate on resolving the FRIs and the complaints, along with redoing the survey process. So I'm assuming, wherever you were in the survey, kind of window, you've been moved back basically 12, 14 months or whatever it is since they've done surveys. So, you know, if you were about to get surveyed prior to the pandemic, chances are you're about to get surveyed now that they're starting to survey again. I don't know that. I do know that the big priority, that at least what they've told us, is the FRIs and the complaints. In terms of the normal surveys, I just assume that they're going to start where they left off. All right, and I think that's all the questions we have for days. Sorry, there were a lot of questions today, guys. If you think of anything else you want me to bring up, please. It's incredibly important that what comes from you gets heard by them. There's not a great flow of information up from you guys, you know, to these folks at CDPH. So we want to make sure that you give us the information so that we can present it to them and say, hey, this is what folks are struggling with. This is what's so hard about visitation. I will definitely ask them to address the difficulty of scheduling and operationalizing these visitation things. I think the more that we get them to acknowledge it publicly of how difficult it is, the surveyors that are on those calls and health departments that are on those calls, they hear that as well. And it just, hopefully it gives them a little, you know, when the surveyor comes in the building, they're not rip roaring and ready to go. They realize how hard it is. So hopefully you guys have a wonderful weekend. I want to say thank you to Jamie and Summer for helping me pull this together and copying all the information down. And if your infection preventionist is not involved in the professional organization, please turn them on to the APEC presentation. I think there'll be a lot of good stuff. If they're new to infection prevention, it should be a good introduction to infection prevention and emergency preparedness and how the two kind of cross over. So with that, I want to say thank you. Have a wonderful weekend, guys. Hope to hear you or talk to you next Thursday at the infection preventionist meeting. If not, I will see you next Friday. Have a great weekend, guys. Bye-bye.